Hello, my name is Jennifer Tremmel. I'm an interventional cardiologist at Stanford.
Hello, I'm Wayne Batchelor. I'm an interventional cardiologist at the Inova Heart and Vascular Institute.
And we're here today to talk about a couple of sub-studies from the AGENT IDE trial. So do you want to give us a little overview of AGENT IDE?
Yeah, thanks, Jennifer. First of all, it's a really exciting time right now in interventional cardiology where we're finally able to have an impact on in-stent restenosis in a meaningful fashion. So the AGENT IDE is the first prospective randomized trial. It was a pivotal pre-market approval study sponsored by Boston Scientific, evaluating the safety and efficacy of the Paclitaxel drug-coated balloon versus balloon angioplasty for in-stent restenosis. So there were 600 patients randomized in a 2-to-1 fashion to receive DCB versus balloon angioplasty. And what the trial showed was a significant reduction in the primary endpoint of 1-year target lesion failure, which was reduced by 41% with the drug-coated balloon. What's remarkable to me is the incredible safety profile, too, of the drug-coated balloon. There were no experiences of stent thrombosis, definite or probable stent thrombosis in the drug-coated balloon. And there were a handful in the patients treated with balloon angioplasty. So there was a significant reduction, statistically significant, also in the risk of stent thrombosis. So this, to me, has really launched us into another era of how we need to look at evaluating and treating our patients with in-stent restenosis. Now, what's even more important, something that's kind of near and dear to my heart, and I know yours, is how do we understand how this extrapolates to subgroups that have not been as well studied in a number of clinical trials within the interventional cardiology world, namely women and outcomes in women and outcomes in racial and ethnic minorities. So I'm really curious to hear, I know that you did a recent sub-study on outcomes in women within the AGENT IDE protocol, and I'd love to hear what your findings were.
Yeah, so totally agree with you. These are both very important subgroups and groups that typically we don't have enough data on. And so was very happy to be a part of that. So what we did was we took the trial and basically separated out men and women. And we had about 26% women in the trial, and then the rest were men. So in the balloon angioplasty and DCB aspect for women, so we had 100 women that were in DCB, and then we had 50 that were balloon angioplasty. For men, obviously, there were more. So there were 200 and some for the balloon for DCB, and then another 150 for balloon angioplasty. And if we looked at men and women across the board, really very similar characteristics of them. We did see that there were more women that were Black or of African heritage than men. And the men had more prior CABG. But other than that, very similar groups. And then women also had a smaller reference vessel diameter. And this wasn't surprising. So something we know from prior DCB trials is certainly in other trials, women have smaller lumen sizes. Women also tend to have more dissections with DCBs. And they also have higher late lumen loss with DCB. These are in other studies that didn't look at ISR. This was actually the first one where we looked at ISR for women and men. So basically in taking those populations, we found that, overall women did very comparable to men, which was great, right? So we hate to see that they did worse in some way. So actually very comparable, showed a significant reduction in the 1-year target lesion failure in women as well as in men. And if we just looked at the women that got DCB alone, there were no significant differences either in those groups. So overall, safety and efficacy appears to be very similar and robust for both women and men.
Yeah, this concept of how women and minorities fare after percutaneous coronary intervention is a really important and interesting topic. Boston Scientific historically has done a landmark study, a registry study called the Platinum Diversity Study, where we actually showed that there was an increased hazard for death and MI in women and minorities after percutaneous coronary intervention. So I was really curious to see how that played out in this study, and very encouraged by the fact that we didn't seem to see those increased risks in women, and the efficacy, the treatment efficacy, was exactly what we'd expect it for women as for men. So that's very encouraging to me. What about this small vessel diameter phenomenon? I know that there was some subgroup analysis presented by Dr. Dohad from Cedars-Sinai, looking at small vessel patients and how they fared with DCB, and he very eloquently presented this morning that there was equal efficacy in those patients versus patients who had normal or larger vessel sizes. What's interesting about the AGENT IDE study is it did include patients from 2 millimeters to 4 millimeters, so a pretty large group of patients, patient vessel diameters. So do you think that it's worthwhile sort of dissecting any further into the group of women who received these particular treatments? What else can we gather from this data set that you would like to study more besides just purely efficacy and safety?
Yeah, I mean, it would be really interesting to see, if we could look at the smaller sizes, compared to the larger sizes. I think it's going to get a little difficult just by numbers, right? And this is always also a challenge with these populations, is that we don't have as high a number. So, so we actually didn't look at that particular detail, but recognizing that in general, women had smaller vessel size anyway. I think very encouraging because, it could go either way, right? You might think, better to, be able to use DCB in these patients who have smaller vessel size, but also, do women fare as well, right? When we're just doing balloon angioplasty in general, right? And is this going to actually offer them any sort of benefit? Are they going to have more problems with it? So, I think that overall, very encouraging. And if we're looking at the future, it would be nice to do really a sex-specific study, right, where we just take women, we randomize them, among their own group, and we can have larger numbers and look at more detail regards to these women.
Yeah. The other thing I was kind of interested in hearing maybe a little bit more about is this phenomenon where dissections were a little bit more common in women. I mean, it speaks to this issue of, myocardial infarction with normal coronary arteries, spontaneous coronary dissections in women. What do you think? Can you read into that? I know they're small numbers. It's hard to sort of make sense of it, but it's an interesting hypothesis generation that there's something different about the vessels.
I mean, I think in general, women tend to get more dissections. I mean, if you look at any PCI population, if you look at ROTA, right, you see more complications, in women with these devices. So, women's vessels seem to be more fragile, right? SCAD certainly as, subgroup of that, where we see something kind of extreme. But even if you look at vascular complications, right, higher in women, dissection. So there's definitely something unique about women. But at least this data says women should get, AGENT as well, and will do just as well as men.
Yeah, really encouraging results. Yeah. Maybe we can speak a little bit about some of the other subgroup analyses that are being done and the data that we have to date on racial and ethnic minorities.
Yeah, so I would actually really like to hear about that. You have all the information on that. Fill us in on what you did and what you found.
Yeah, so similar to your subgroup analysis, this was a pre-specified analysis where at the beginning of the study investigators thought that it was important to purposefully look at racial and ethnic minority outcomes in within the context of the clinical trial. So out of the 600 patients that were included in the overall trial, 148 were self-identified as minority. Minority status was basically just through asking the patients how they identified in terms of their ethnicity. So they had to specify Hispanic or Latino or non-Hispanic, and then they also had to specify their race. And so you could have more than one race specified, but the traditional racial subgroup categories that the U.S. Census uses, Black or African American, Asian, American Indian, Alaskan Native, and Pacific Islander, were all included. It's important to note that the Asian category included all Asians, so there was not a lot of specificity around that group. We found that 28% of patients self-identified as being Black, 22% Hispanic, 10% Asian. There was a group that was not specified. In some cases, individuals just didn't either specify their race and ethnicity, or maybe they didn't want to. But that was a significant cohort. Around a quarter of patients were in that group. But we looked at patient outcomes for all minorities versus those outcomes for non-Hispanic whites. And what we saw was relative to the reduction in target lesion failure at 1 year in whites, the point estimate was actually more favorable for minorities, which is really encouraging to me. Again, the p-value on that was 0.08 because of the smaller numbers of patients, but at least we saw the Kaplan-Meier curves separating more in the Black and other minority patients than in whites. So that's encouraging to me as someone who's kind of studied outcomes in particular underrepresented minorities. I was pleased to see that. And then furthermore, again, really good safety, no stent thromboses in any of these groups. And also target vessel revascularization, target lesion revascularization was significantly reduced with the DCB in minorities versus balloon angioplasty. So again, better separation of the curves than we saw for the white cohort, which is quite interesting because minorities had a significantly higher rate of diabetes. 60% of minorities were diabetic versus a little over 40% in whites. And despite that, we saw really effective reductions. So I'm encouraged by that. I think we have to sort of do a deeper dive and really look at the data closely and hopefully write it up and publish it, because I think it's very important that we carry this through.
So what do you make of that? I mean, why do you think there might be a trend even, in favor in this situation?
Yeah, I think anytime you have an event rate that is likely to be a little higher in a particular subgroup, we've seen with Blacks and Hispanics, again, the major adverse cardiac event rate at 1 year through the Platinum Diversity Study, and other groups have seen this as well, it's higher. And in particular, diabetic Black women have really high event rates at 1 year. So I think that if you have a really efficacious intervention that works to reduce the risk of target vessel revascularization, I think you're going to see it perhaps even more exaggerated in groups that have higher risks to begin with. That's the hypothesis I'm working on. But it's reassuring because some of these groups are difficult to treat groups. The diabetics, they're more likely to have more diffuse restenosis and more advanced disease. So to see these efficacy reductions with the safety profile being, very, very promising, to me is a nice signal.
Mm-hmm. And were you able to see any differences between the racial ethnic groups, or is that too fine for this? Yeah,
it's difficult to slice and dice to that degree, and we're going to have lack statistical power to evaluate that. But we didn't see any obvious differences. Everything looked around the same, but I think we have to interpret that with caution because the numbers get to be pretty small.
And if you had enough numbers, I mean, is there, based on, kind of historic information, is there one group you would expect that might benefit more or less?
Yeah, it's a really good question. I can tell you that from the limited data that we have, it looks like outcomes in Asians after percutaneous coronary intervention, their MACE rate in a study done by Guillaume and looking at thousands of patients in multiple clinical trials, Asians actually had the best outcome at 1 year in terms of MACE rates. And then it was non-Hispanic whites, and then minorities, and the highest rate of MACE was actually in Blacks. So I would think that particularly African-American patients, probably also Hispanics, and then we just don't have enough numbers to understand some of the nuances in American Indians, Alaskan Natives, and Pacific Islanders. But certainly African-Americans who have a high rate of diabetes and other comorbidities, in my opinion, stand to really benefit from this and other interventions that reduce risk at 1 year.
Yeah. And what about barriers to getting these devices? Anything that you're concerned about or anything that we should do to hopefully enhance that?
Yeah. This is terrific science, but the reality is there's a lot of other factors that are at play. One group of factors include social determinants of health that have a significant impact on your 1 year outcome. We've shown that in Platinum Diversity. access to healthcare, access to PCI varies across race and ethnicity. So this, unfortunately, doesn't study that phenomenon. That's a separate problem that we have to address at a larger sort of social and community level and political level. And then on the other side, we also need to understand how access to care influences the availability of these devices for patients, because part of the challenges we have in studying outcomes at 1 year in various groups is understanding if they have equal access to the technologies that work the best. And that has to be teased out. The nice thing about this trial is everybody was randomized. It was either 2-to-1 to get the DCB or BA. So it allows us to isolate the impact of the actual intervention on the outcome rather than some of the other factors that really sway outcome a lot. They're still going to have an influence, but at least the randomization makes sure that the baseline characteristics are similar between groups.
Yeah. Yeah. And it would be nice if we had kind of even more numbers that we could divide out race and sex, because, I mean, as you brought up, we know there are differences there too, in terms of, certain women of minorities and men of minorities and that sort of thing. So ultimately, that's something we'd like to really understand, I think, down the road.
Yeah, Jennifer, I think we're scratching the surface on this issue. I think we owe it to our community and to the U.S. population and the population even outside the U.S., because this has implications outside of the U.S., to ensure that, the scientific sample from which we're drawing our conclusions on safety and efficacy, the clinical trial database, is reflective of the intended use population. Historically, it has not, and we've got to do our due diligence. That's not an easy thing to accomplish. I know the FDA, the NIH, all stakeholders, industry, academicians are very interested in this. We're going to have diversity action plans coming out. We're at the beginning of major PMA trials. We're going to have to try to explain how we're going to try to achieve diversity. But to me, this is really mission critical for the next 5 to 10 years of how we structure clinical trials. Because if we don't have those patients involved, we have no idea how this is playing out. And there are differences within groups. I'm reassured by the fact that efficacy and safety was excellent in AGENT IDE for all groups that we've studied so far. We still have to peel the onion a little further. But we can only do that if we have representation. So to me, this is a little bit of a call out to action to all stakeholders involved in clinical research to make sure we get those patients enrolled.
Yeah. So, I mean, I think overall what we've seen is that the drug-coated balloon is safe and efficacious in all our patients, and certainly should be offered to all of our patients who will benefit. And there isn't a certain subset at this point that won't benefit, and it may actually be more beneficial to some than others. And certainly larger numbers would tell us that in the future.
Yeah, I think you just hit the nail on the head. That's a really good conclusion in terms of where we stand with regards to drug-coated balloon technology in 2024. We'll see what the next few years has in store for us.
Yeah, well, wonderful to speak with you and hear about your successful analysis.
Yeah, and thanks for your terrific work in your subgroup analysis. Really excited to see it hopefully in publication in the future.
Thank you.